of this session. Goodness, so exciting. So welcome to our workshop, our final one. This is our Sweat the Right Stuff, Innovative Educational Modalities for Conflict, Allyship, and Mistreatment. Some really golden keywords there. And I will let our speakers introduce themselves. Please, though, I just want to encourage people to chat things in the comments as we go along. I feel like the more that we can just brainstorm and learn together, the better for us all. So please do that.
Great. All right. Hi, everybody. I'm Isabel Green, and we are here to talk about innovative educational modalities for trying to teach, support development of skills and management of conflict, allyship, and mistreatment. I have our objective slide, and then we were going to introduce ourselves and talk about what we do as people kind of get settled. But we obviously want to leave here recognizing the importance of providing our learners with skills in these areas in conflict management and navigating mistreatment and becoming allies in their clerkships and future residencies. We also want to give you tools to take home. So we're going to describe some existing educational modalities and some really good resources for these often underdeveloped and sort of difficult to address skills. And really, we want you to be prepared to implement something small or something large at your home institution. So the three sort of big topics we're going to hit are professionalism lapses, conflict navigation, and then we'll wrap it up with mistreatment and allyship, which I think is the hardest topic. I'll introduce myself a little bit more. So these are my two fellows. This is me in Mayo Clinic. I am at Mayo Clinic in Minnesota, as you might be able to surmise by my clothing choices this afternoon. I have a lot of hats, as many of us do, both in GME and in the med school, and specifically in the med school, running a transition to residency course. And there's my email at the bottom. And I'll let Sarah introduce herself.
Well, Isabel, I wish I included a fun picture now. Mine looks
well,
so
I
stiff.
couldn't. I'm telling you, my securities, it's like, we don't trust. I was like, you don't trust my professional picture? So I had to find something casual.
I love it. I love it. Well, hey, everybody. Thank you for joining us. I know it's been a shift in everyone's schedule, so we really appreciate that people were able to join. I'm Sarah Paige Ramsey. I'm down in San Antonio, Texas, where the weather's a little bit warmer than where Isabel is. And here I'm the residency program director. And honestly, that is about 20 hats in one, I think. So I currently don't carry a whole lot of other hats because that takes up the majority of my time. But I have been a previous clerkship director and previously ran fourth-year student clerkships as well, and then have been involved in the Step Up to Residency program and the APGO medical student course, and a previous APGO UMEC member. So lots of undergraduate medical education experience as well. So I kind of love all levels of learning. I guess my areas of interest are really medical education, like all of you, and then in particular simulation. And there's my email. Would love to collaborate with any of you on anything.
Hi, my name is Sylvia Botros-Bray, and with Dr. Paige Ramsey. I am at the University of Texas Health in San Antonio. And so I have roles across the continuum. I'm a module co-director for Medicine, Behavior, and Society, which is our professionalism and ethics course for the first year and part of second year medical students. I'm a program director for our Female Pelvic Medicine and Reconstructive Surgery Fellowship. And I'm the executive director of our Academy of Educational Scholars, which we founded probably 2 or 3 years ago. So my interests lie in both faculty development in education as well as professionalism across the continuum. And I have a particular research interest in resident perceptions of mistreatment and an innovative tool called forum theater that allows for both reflection and problem solving.
We're so excited to share that with you. I was new to that, so I'm really excited to have you with us today, Sylvia.
Happy to be here.
So when we think about professionalism, I think I always hate this question, what is professionalism? How do you describe professionalism? What is unprofessional? And so part of our goal today is to almost even just change the framework of how we're thinking about it. Because I think by changing that framework of how you think about professionalism and unprofessionalism or lack of professionalism, it can make things a little bit more concrete for teaching it. So for example, instead of thinking about professionalism itself, thinking instead about professionalism challenges. So what are those situations that might make it difficult for an individual physician or physician in training to remain true to their values, to their professionalism values? And then kind of a consequence of a professionalism lapse. So an error in judgment, skill, or attitude that leads to an otherwise competent physician behaving in a manner that seems contrary to our established norms. So kind of going forward, instead of thinking about professionalism, we're going to think more about those challenges and those lapses and really trying to address that instead of what we think a norm or a value might be. So when we think about things that do lead to those challenges that kind of I tell the residents or the students as I'm teaching, the things that sort of impact me in whether I'm going to be my best self or sort of my not best self would be my own self-intent, my sense of self-efficacy, my positive role models, and then kind of on that flip side, those negative role models, those really stressful situations that, you know, in OB/GYN we find ourselves in probably more often than not. And then, of course, we can all understand how burnout can affect all of us in our ability to be our best selves in every situation. So really the charge that we place on our learners, you know, we keep talking about role modeling and hidden curriculums and sort of trying to always be our best self, is that we charge learners with that sense that they have a choice whether to propagate or mitigate professionalism lapses, mistreatment, microaggressions. But the reality is that with our fast pace of duties, training expectations, and then really minimal time for guided reflections and minimal tools until I kind of met this group here, which is these amazing women colleagues, minimal tools to sort of teach how to create intentional behavioral change and be better in those challenges and better in those situations. So we've got this like charge that we place on them, but the reality is we don't all have a lot of time and tools to make sure that we're teaching and supporting them in that reality. So I'm going to hand it over to Sarah now, who's going to talk a little bit about conflict.
All right, so certainly conflict is not something new to any of us, but I think for many of us, we are uncomfortable handling it. And, you know, that's not something that we often get formal training in. When we really look at what exactly is conflict, you'll find lots of different definitions, of course, and it certainly can apply to many different settings, many different areas, not just healthcare, but it's really when there's an incompatibility between two or more opinions, principles, or interests, right? So when two people have different perspectives, different viewpoints, different things that they value, that you may end up in a conflict situation. When you look at, you know, where it really comes from, if we could go back one slide there, where, you know, kind of the origin of the term from Latin was really about more centered around fighting. And, you know, actually striking is where the term figere comes from. So that turned into the Latin configere, and then eventually conflictus, and then conflict. And so that's kind of where it came from, was really battle and fighting, but we certainly see it in many non-physical ways as well. When we can go ahead. When we look at, you know, in the healthcare systems, there's a lot of literature that's looked at what are the most common types of conflicts that we may see in the healthcare environment. And certainly that's something that our medical student learners, resident learners, and our faculty deal with on a regular basis. And many times when you really boil it down, it's about either task conflict. So there's some differing opinion or perspective about how a certain task can be, or you're getting pulled in two directions, or you have two different goals as far as tasks to achieve. Many of us as medical educators understand that one really well, because our tasks are often centered around education, and our chair's tasks may be more centered around revenue and financial productivity, and sometimes those two may collide. So that's an example of task conflict. Whereas relationship conflict can just be differences in personality, differences in the way we handle things in the workplace. And then of course, value conflict. And that's certainly something that we've seen on a regular basis, especially here in Texas this year. Different conflicts centered around very critical issues that may apply to our patients or to our learners may introduce value conflicts that we have to engage. So this was actually an interesting report looking at 300 healthcare providers. And these weren't just physicians, these were all types of healthcare providers at a large academic center. This was actually done in Canada. But about 26% of those healthcare providers felt that they were adequately prepared to manage conflict in the workplace. So in other words, looking at it with the glass half empty approach, I guess that means 75% were not prepared, which is pretty concerning. Not prepared to manage conflict when we know it comes up on a daily basis. And a little over half of them felt like they really needed more training in this area. 3/4 of them really wanted to see conflict management training that was somehow incorporated into their own career preparation and ongoing training. So people really felt this was a valuable thing to introduce into career and professional development. And actually almost 80% wanted to see conflict management incorporated into medical school so that we could begin to teach our very youngest learners how to start managing and handling conflict from an early stage on. So clearly it's very important to all of us.
So here we already wanted to ask our participants to use the chat function and start to think about what are some existing gaps in training that you have right now for managing professionalism lapses, challenges, and conflict navigation, where opportunities might exist for training, and who some of your key stakeholders might be that you could lean on for this. And at least have it be a personal exercise, but we love it when people can kind of throw out, I call it chat splash, which I borrowed from another educator, just to sort of get a sense of where people feel like there might be some opportunities or gaps at their own institutions before we go forward. Right now, we're just reflecting on Sarah's amazing professional photo.
Oh my gosh. Thank you. Thank you, Tammy, for throwing something in the chat. So it looks like Tammy every 2 years has a conflict resolution didactic as part of the quarterly leadership development series. So is that, Tammy, is that for faculty or is it for your learners as well?
Yeah, it's actually, so we moved away from our residents as teachers nomenclature, and now we have this kind of leadership development series, and it just allows for then a broader scope instead of just focusing on just necessarily teaching skills, but also leadership skills. And so we do like the TKI together and kind of like talk through the different various types of conflict resolution profile types, learn a little bit about kind of ourselves, and then have discussions and case scenarios and vignettes. And we rotate around different cycles every 2 years. So I love what you're bringing up here and would love to learn more. But yeah, this is a little piece of an insert of where we embed that.
Excellent. Okay, well, I hope people are at least reflecting on already some thoughts of where the gaps might exist, where some opportunities might exist, and some people that they might want to start to align with and think about aligning with in trying to address this with the students and residents. So I'm going to move on and talk about some exercises we do at Mayo to address the challenges and lapses. And I think about it as practicing pivoting in a professionalism challenge to then avoid a professionalism lapse personally. And what we do is for the medical students, we have a hybrid session. It's 90 minutes. It takes 3 faculty for 30 learners. So we try to keep the ratio pretty low. And we do this in our transition to residency course for the 4th year medical students. The first part of it, we ask the learners as a large group to reflect on the work, on the clerkships, on the time that they've had thus far, and think of an example of a professionalism lapse. And we do a group share to sort of set the stage of what some of these examples might look like. And then we introduce some didactics. And actually, Tammy, I have them do the the Thomas Kilman Index the night before and submit their sort of go-to conflict style. So they've already done that. But you can or can't include that, it doesn't matter. But we do a didactic session reviewing concepts of professionalism lapses, and then have them work in small groups as they review examples and provide some solutions. And then we share that back with the large group. So I wanted to share some resources that we have through Mayo and through the Kern Center. So let me get rid of the chat for a second. Got too many things on my screen. So this Kern Center link, if all of you can see that, the Kern National Network, yeah, thumbs up, has a lot of really amazing resources, and this is available outside of Mayo too, so you don't have to be within like our firewalls and stuff. Of the Take 5 videos, so very short sort of faculty development, learner development on each of these topics, reducing bias, microaggressions. And there's one specifically on something called the professionalism pivot. And I was actually going to have us just take a minute and take a look at that video together.
Hello, my name is Andrea Leap, and I'm a neurologist and associate director for the Mayo Clinic program in professionalism and values. Today, I'd like to share a set of 5 tips and tricks for responding to professionalism lapses in the learning environment using a strategy I like to call the professionalism pivot. Now, when we hear the words professionalism lapse, what probably comes to mind for many of us are pretty egregious examples, like the physician who has inappropriate relations with the patient, or falsifies records, or comes to work intoxicated. While these types of offenses unfortunately do occur, thankfully they're rare. Much more common are the day-to-day challenges in mutual respect, incivilities, and other professionalism lapses that occur in our work environment. A disparaging comment about a patient, a condescending statement toward another service, or remarks that could be perceived as discriminatory or stereotyping, even if made inadvertently. While less severe, these cumulatively have a big impact on our learners. As faculty, we play an important role in setting the tone for the learning and the practice environment. So we need to not only be able to recognize these lapses when they occur, but also respond to them in an effective way. So let's go over 5 tips for how to do this from the book Understanding Medical Professionalism. First, respond in the moment. We may intend to approach the lapser later in private, but often later never comes. Responding in the moment helps immediately communicate professional expectations to both the lapser and those who witness the event, and avoids the risks of remaining silent, which can send a message of tacit endorsement or perpetuate damaging stereotypes about our patients, our colleagues, or our learners. Second, recognize underlying emotions. Lapses often occur in situations that are stressful, time-pressured, or when we're not at our best, due to fatigue or competing demands or running into a systems issue. These types of situations trigger strong emotions, and recognizing those emotions is a very helpful way to start an in-the-moment response to a professionalism lapse. This can be accomplished with simple phrases like, "I can see you're frustrated," or "It seems like you're getting tired and overwhelmed." Third, relate to the lapser by saying something along the lines of, "Sometimes patients make me feel frustrated too," or "I remember what it was like to get bombarded with pages after being up all night." Fourth, reestablish the professional norm, and often it's helpful to use a we or an us statement, like, "We should remember the patient's not feeling well and they're probably pretty frustrated too," or "Let's keep in mind the nurses have a lot on their plate and they're working hard to take care of our patients." Fifth, redirect the conversation. This is where a supportive or helpful offer can be really useful. "How can we help you take care of this patient? Would it help if I carried the pager for a while?" Redirecting the conversation like this helps shift the focus off the lapse and the lapser and back onto the needs of the patient or the task at hand. This simple and supportive professionalism pivot should take no more than 90 seconds and can be used by anyone. As faculty, we can not only role model this approach, but also teach it to our learners and invite them to use it on us, because inevitably there will be times when we fail to demonstrate the professionalism to which we aspire. So to recap, when you witness a professionalism lapse in the workplace, respond in the moment, recognize underlying emotions, relate to the offender, reestablish professional norms, and redirect the conversation.
So I don't always understand why it has to have the fun music, but I do like the concept of those 5 principles. And so we don't actually show them the video or have them view the video, but we're using that video, which is why I think that's a really great resource for just some inspiring topics and some models and sort of infrastructure to have a teaching session with your learners, whether they're students or residents. So we do review this with them as part of the didactic session, these principles, and then we go on to case studies, and we break them up into small groups. And here are some examples. And then we just ask them to sort of think about how they would create their own pivot and practice it within their small groups with our learners. Another example that we have is introducing that concept of the third story. So trying to look at it from an outside perspective and also having some self-awareness. So this is where the Thomas Kilmann instrument for conflict management does come in that I used the night before. But we ask them to read through the cases again as a group and really think of that first gut response, sort of what is your initial feeling? What comes to mind? What do you feel most likely to say? What does your instinct tell you to say? And then we have them share those as a group and think about what might be contributing to the stress during those exchanges, and then providing alternatives. So almost saying it's okay to have these instinctual feelings and responses, just sort of giving them that skill to recognize it and start to come up with an alternative way of expressing themselves and trying to pivot within that professionalism lapse. So here's another example. We all read very quickly because we are physicians and things like that. So you can take a look at that example. But we have a bunch of these and go through them so that they address things like emergency room kind of navigation of professionalism issues. So between services, patient to provider, and within providers as well. So we've got that hybrid session between a combination of didactics and the small group. And I get to actually run it with Andrea, the speaker in that professionalism pivot video. So here we put it in here at Mayo, we put it in our transition to residency course. We put it in our professional development part of our didactics, the teach the teachers thing. And then we even have some faculty development exercises. So before we move on to Sarah, we wanted to just, again, use that chat function or maybe have someone share with whether, this speaks to them or could be something that they implement. And that way we can kind of, as we go along, address any questions that you might have on how to implement it. And I'm seeing what I love about the video is that it's so brief. Thank you, Sarah. Yeah, it's a really nice infrastructure. Like I said, a building block, just somewhere to start, so you're not starting from scratch and making it up on your own. And those links should be in the materials that were part of the syllabus. But what's nice is that I can also include the link here in the chat. So I'll do that too. Oh, you got it. Thank you.
Isabel, the other thing that I think is so great about your program is that
You've found a lot of areas that you can pull it in, that it's helpful to a variety of different learners. And I think that that's really an important takeaway message too for all of us, is that, sometimes professionalism is so overwhelming because it is such a broad topic. And I think we try to tackle all of it at once. And sometimes just doing small pieces at a time, or kind of giving it at different sessions throughout the year is a great way to kind of keep that always consistently on the surface, and really that, helping to make a culture change toward professionalism.
Thank you.
Jane shared, some of my residents kind of roll their eyes when they see conflict resolution, professional development, wellness, et cetera, on their schedules. How do you create buy-in from the learners, Isabel?
Yeah, that is a great point. It's interesting because inevitably there will be about 75% that enjoyed the sessions and 25% that probably felt that it was not as helpful. And those are probably the 25% that could benefit the most from it. And so I think I'm really excited for you to hear from Sarah and from Sylvia with some additional tools that I think you can use that might be more resident generated in terms of getting their buy-in by having them be part of the design process in the session. I think for me, I've tried to create examples at least that I think speak to them. And I've tried to make it a small part of a bigger session. So maybe not doing 2 hours on wellness, but kind of dividing it into something that I know that they'll really like a coffee break, combined with something that they might roll their eyes at. So sometimes not overwhelming them with 2 hours of conflict resolution and management for sure. But great point. I think Jane, at the end, let us know what you think after you hear about all the options. So I'm going to hand it over to Sarah, and Sarah, I'm going to mute myself if I can. Yep. So you just let me know if I need to advance or anything.
Okay, will do. Okay, so I'm excited to share a resource with you all that I think really helps a lot with dialogue in conflict resolution and just approaching conflict in a healthy way. And so I don't know, how many of you have any of you ever done crucial conversations? Maybe show of hands, or I'm just kind of screening through, or maybe join in the chat if you've done it before. But when I look back at my career development, my professional development so far, there's kind of 2 books that really stand out to me the most that I've gone through, or training courses. And one of those was the 5 love languages. And I actually first heard that at an APGO faculty development seminar, like in 2005 or 6. And I was completely blown away by it. And I've used it in every aspect of life. Jill says yes. And then the second one is that it's crucial conversations. And crucial conversations, I actually only recently attended about maybe 4 years ago. So at sort of the midpoint in my career. And I attended it with several other physicians and nurses that I work with, and some allied healthcare professionals as well. And it really resonated with me that there were so many pearls that I took away from it, because conflict's so uncomfortable for so many of us. And then it started to occur to me how valuable this would be for our more junior learners as well. And so what I'm hoping to do is not just introduce you to crucial conversations, but also to just encourage you to consider using at least small chunks of it for even your junior learners. So basically what Crucial Conversations is it's actually a 10-part course if you do the whole full formal course, so it can be quite lengthy, but they have a lot of different options that are available that I'll go through. And it addresses 9 key components to approaching conflict, not just in the workplace, but it could be used in your personal life as well, but just kind of key components to addressing conflict. So we'll go to the next slide. And this is just kind of an introductory video that Crucial Learning is the company that runs, sorry, this will be an ad just for a second. But Crucial Learning is the company that kind of runs the training. And they have this introductory video, which I think just kind of highlights what the program tries to achieve.
or quality, it can lead to low morale, reduced efficiency, increased costs. When people feel they can't discuss difficult workplace issues or be candid about performance, projects, or quality, it can lead to low morale, reduced efficiency, increased costs, and project delays. Imagine what your organization could be like if it fostered an environment of open dialogue and mutual respect. How would such an atmosphere affect employee satisfaction, productivity, and the results your team's trying to deliver? Fortunately, there's a way to promote an environment where people speak to one another openly and respectfully, even when the stakes are high, opinions vary, and emotions run strong. Introducing Crucial Conversations training from Vital Smarts. The Crucial Conversations course teaches important skills for individuals, teams, and organizations that suffer from outcomes like poor quality, slow time to market, declining customer satisfaction, or strained relationships. Achieve immediate, measurable, and sustainable results by creating conditions in your organization where people speak with complete candor and openness, no matter the topic. Put Crucial Conversations training to work and you'll drive rapid and sustainable change, get stalled initiatives back on track, and turn mediocre performers into key contributors. The training teaches participants how to resolve disagreements, build acceptance and overcome resistance, speak persuasively, not abrasively, about high-stakes, emotional, or controversial topics, foster teamwork and better decision-making, build teams that work together and act with unity and conviction. The training is also easy to deliver with multiple in-person and virtual rollout options available, including certification courses, in-house programs, and 2-day public workshops. Crucial Conversations training is backed by more than 30 years of research and a New York Times best-selling book. The award-winning training program has helped more than 2 million people and 300 of the Fortune 500 companies realize powerful results using a proven method for driving rapid, sustainable, and measurable change in behaviors. Find out how Crucial Conversation skills can drive real change in your organization today.
So as you can see, that's a little bit of a kind of an, obviously it's an advertisement, but I think it kind of helps you to understand. If we can go back one slide if we can. Isabel, I think you might have gone forward one. Oh, no, sorry. There we go. That's the one. And so I know it's a little bit of an advertising type of a video, but you can see it applies to lots of different disciplines. It's certainly not directed at medicine specifically, but you can model some of the examples and scenarios if you want to toward medical trainees. And certainly the principles still stand. And so I've kind of displayed here for you the 9 different principles that they go through. And you can certainly do this course in small chunks over time, which helps you to kind of focus on one thing at a time, and the learner builds on the principles that they've learned before. And so it's really a fantastic program, whether you use the book, whether you do an in-person course, et cetera, really moving through these 9 steps and learning how to approach conflict. I don't know about you all, but we've had kind of more and more issues have come out on either our ACGME survey or our own internal surveys about conflicts with other healthcare providers for residents, that residents feel like they're dealing with that a lot. Medical students feel like they deal with that a lot. So this really helps them to learn how to approach those. And I have found it to be very successful in approaching conflict in situations that I previously really struggled with, certain folks that maybe work in the healthcare system and have been able to make successful change with a mutual goal in mind. So we'll go to the next slide. So the Crucial Conversations or Crucial Learning team, they actually offer this in several different ways. There's an on-demand, so the resident or the medical student can actually learn the modules at their own pace completely if you wanted them to do it totally independently. Or you can kind of combine that to a more hybrid model, which I'll demonstrate as our example in just a minute. You can do it virtually, meaning they're watching it at a certain time and they're participating with other people from all over, kind of like what we're doing right now. And then, of course, there's the traditional in-person where you attend a classroom course, which is the way that I attended Crucial Conversations. Yeah, next slide. So just as an example, I'm going to show you probably one of the ones that helped me the most and that I'm still working on in my own professional development is mastering my stories. And so really what this means and what you learn in Crucial Conversations is that many times our reaction to conflict is because we're making a lot of assumptions about what the other person thinks or feels. And so that causes an emotional response for us, and then our behavior changes as well. And so the course really teaches you to just stick with the facts try not to introduce your story and recognize that your story is actually driving your emotion, not usually the facts. And so the next slide, I'll show you just kind of a little tidbit of an example of one of the learning videos centered around the storytelling.
You know, my wife's like, "What'd you do?"
And that's not the right one. Sorry.
I wish you could have heard my original laugh. That was awesome.
That's it. That we all just had a story in our mind on that one.
That was awesome. Here we go.
So when it's clear that someone is making a decision that may be based on some biases they have, I think one of the important things to remember as you address the conversation is really mastering your own story about why that person may be doing it. Could there be other reasons for the decision that maybe you're not aware of? You know, maybe it's limited information or possibly even exposure that they may have that could be impacting that decision. Us, again, starting with working on ourselves first, kind of mastering our own stories, is going to be the catalyst when we actually engage in that discussion. And so as you go into the conversation, again, remember, use facts. You know, last week you decided this, you stated this about this candidate, whatever that topic was, clearly articulate the facts first, and then share your interpretation of those facts, watching how you share that story. Most important, invite them into a dialogue, because again, you are making a guess of what may have influenced that decision, and you really want to get that person to open up and say, yes, I did, and here's a little bit more behind it, or wow, I wasn't even sure that I did that. Please help me figure out how to fix it. It's all about getting us to that dialogue. And so again, I would suggest number one, mastering our story around why they may have made the decision that was made, and number two, using the facts, sharing our story, and inviting them into a conversation, which is going to help us really close the gap on some of those biases. Thanks for watching.
So you can see kind of in line with today's learner, it's short, it's concise, it gives some great take-home points and something that they can easily fit in. So we'll go to the next slide here. And just this is an example of how you can combine the on-demand sessions with an in-person, because one of the biggest concerns for me with on-demand things is I'm not sure our learners always watch it. I think some of them do, but I think some of them don't. They have a million other things going on in their life too. And so what this model does is it actually forces people to participate in the on-demand portion, because there's going to be some after work that's going to require that foundation. So basically what you can do is set a scheduled time. So don't just say, get this done by February 15th, but you actually have it built into their schedule. So there's a set time where their task is to actually watch the on-demand session. And so that takes anywhere from 30 to 45 minutes, depending on the particular session. So they complete that on their own. And then we have 15 minutes during which time they have a reflective exercise. So we give them a task. So their task is reflect on the last week of your work activity and write a personal example of a time where you created a story in a conflict that you engaged in some way. So what was your story and what was this negative story that you created? And so then the learner brings that reflective piece to the group session. So the group session is sort of scheduled during your regular didactics, or maybe you have it during a leadership course or wherever you want to use that. But that group session, then everyone brings their examples, they place them in a box, and all of the participants draw one out of the box. So they're looking at somebody else's example and they don't know who it is, whose example it is, but then they actually share the tools they've learned from the on-demand session to help the person solve that conflict and approach it in a more positive way the next time. And so it really helps the learner to kind of engage in the on-demand part and then actually bring that back to the group and help to teach. So it's very involved, very interactive, and really kind of puts the responsibility on the learner to really take it seriously. So this is just an example of a hybrid session. And if you do this type of a session, you'll have, it'll essentially end up being about 18 hours a year if you were to try and do it every year. 9 of those hours would be on their own. but scheduled in somewhere, and then the other 9 hours would be together. So this is just one example of a way that you could implement the curriculum for your learners. Another example on the next slide is that if you're really more strapped for time and you're looking for sort of a more abbreviated approach, then this was one that I actually found as well from another educator, where they actually created this really nice summary sheet that just highlights some very critical points from the different 9 steps. So rather than having people go through the entire course and spend that hour of time on their own, and then that hour of time in the group or anything along those lines, what they did was break it down into very small sessions that could be even as short as 10 minutes to review key concepts from the different lessons, and then provide these summary sheets that help give people reminders. So I thought this was a really nice approach too, especially if you're a little bit more strapped for time. Okay, and so we've probably only got about maybe a minute for any idea sharing, because I don't want to bite into Sylvia's portion, because her stuff is fantastic. But anybody else want to share how they might fit this into learners' schedules, or whether they can think of any other models to implement it into the curriculum, or maybe places where you feel like it would be useful in your curriculum?
Sarah, I wonder too if like context helps. Like I feel like for my residents, there's that first thing that's like immediately visible, and the students too, which is sort of just navigating the hospital system and all the different hierarchies. But then I feel like as they're getting ready to graduate and become junior faculty, I feel like crucial conversations would be so helpful for navigating those issues as you're asking for things to be effective in your job, right? Like, how do you have a good conversation with your chair? How do you work with your division chair? How do you navigate like working with operating room staff? Just that like upper level, this sounds even more sophisticated, and I think would be incredibly helpful to not take many years of experience to get these skills under your belt, kind of thing. So
yeah, well, we've definitely pulled little pieces of it into our Rising Chief Resident Leadership Day as well. So we do a full day for our Rising Chief Residents, and have pulled small tidbits into that as well for exactly what you're talking about, because now they're going to be the leader of their team that next year, and kind of learning how to handle some of those conversations.
Yeah. And I like that they're generating some of these ideas, which hopefully, as we were talking about before, might get some additional buy-in. When Jane was mentioning, the eye rolling, they're generating the issues.
Yeah.
Okay, Sylvia, you're on.
I just hope I can live up to all this hype, you guys.
It's just so cool. I love it.
You can.
So I just had a really strong interest in the learning environment, cultures, mistreatment. We all go on these journeys at different paces. And I think that, the 5 love languages and crucial conversations were things I had done maybe back in 2017. And even, I think that was the year that a lot of this came up. And I transitioned to a new environment. And it's a very different environment from where I was. And so I just kind of was looking around and, starting to ask, these questions, plus had this real big interest in medical education, faculty development. So it all just kind of aligned. I went on a trip to Haiti with our Center for Medical Humanities and Ethics director, and she introduced me to this thing called forum theater. And I thought, what is this? And it was one of those things where she's like, I'm willing to help. I'm happy to mentor you. But only if you use forum theater. And I just kind of started laughing, but I was like, okay, well, what is it? So let me just back up and let's talk about mistreatment for a little bit. We talked about professionalism lapses and how you can pivot. We talked about conflict management, but what if those things don't work? And then you have a bunch of these little interactions that rise to the level of mistreatment in your culture. And someone told me that mistreatment ends up being a manifestation of your culture. So if there's a lot of mistreatment in your environment, it's worth looking at the underlying environment. So it becomes a more complex problem. And I think that's why the problem of mistreatment is such a problem, because you're seeing kind of the end stage of like a deeper problem. So I find it really challenging. And I would ask you, when you hear the word mistreatment, what comes to mind? And do you think about culture or not? You can take a minute if you guys want to share any reflections on that question. Maybe I answered it for you all. Do you, just to show of hands, I mean, do you find this as a challenging, do you find this as a challenging topic? So Dr. Green says, I have a hard time as it doesn't seem very intentional, belittling people, disrespect, treating people as though they are lower than you. Yeah. Mistreatment is a manifestation of your culture. Love that statement. A huge challenge for us. Yeah. When students complain about mistreatment in our clerkship, it's almost always a moment where I can see the resident stress behind it. Yes. So you guys are seeing it, right? It's really complicated. And I think to not treat it as a complicated problem, just, that's why we move out, right? It's too overwhelming and we move on. So how can we even start to scratch the surface with this? Let me go to the next slide. And yes, burnout is real. So just to, pose the problem, this article came out in the general surgery literature about discrimination, abuse, harassment, and they actually were able to survey I want to say upwards of 90% of all general surgery residents nationally, because they tied it to their in-service exam. And no surprise, they found that burnout was tied to harassment, discrimination, and abuse, and actually related to gender, because it seemed like women were exposed to this more than men, but nonetheless, a good portion of surgical residents had experienced it. What they also found was it wasn't really tied to anything structural. It wasn't surgery per se. It wasn't large programs or small programs. And so they concluded that there were probably local, social, cultural aspects of the environment that contributed to mistreatment. And that line really struck me, local, social, cultural aspects, because that's what I saw. Like when I moved from one place to another, it was just really different. The second article, the academic medicine article, is perception of medical student mistreatment and does specialty matter? Can you guys guess what the top two specialties listed were? Surgery and Ob-Gyn. Yep, for sure. Exactly. Yeah, it was Ob-Gyn and surgery. I don't think that's news, but here it's documented. Can we go to the next slide? All right, so let's just talk a little bit about definitions. And so the AAMC has a definition of mistreatment, which I think is actually really helpful if you stick to it. And so there's intentional or unintentional events that occur when behavior shows disrespect for the dignity of others and unreasonably interferes with the learning process. And so sometimes we think about these, I think, Isabel, you were talking about like the more egregious things, or someone was mentioning something earlier about we focus on the more egregious behaviors because that's a little bit maybe easier. But if you, what about those little kind of dings that we're just talking about? Someone belittles you, that disrespect here or there. And sometimes those things are intentional, sometimes they're not. And so they're really, it's just those what do you do moments. I think it's very similar to microaggressions, except we're not talking about marginalized populations. We're just talking about everyday interactions, and they can affect your learning. So culture then is the set of ideas, behaviors, attitudes, and traditions that exist within large groups of people. And that includes a shared set of, and I like this, implicit and explicit values. So it's that implicit part that can sometimes be hard. And they're basically rules of behavior that allow a social group to function and perpetuate itself. And sometimes it's hard to change. So, that's why culture is so important. All right, let's go to the next slide. So just again, back to a little bit of prevalence, many surveys have been done on mistreatment in students and residents, and they all generally say very similar things. It happens up to 30% in general surgery, unless we think it's only the surgical specialties. A 2020 article showed that it shows up to 33% in pediatrics, and one meta-analysis showed about a 63% prevalence. So it happens. it happens everywhere. And so our own Maya Hamoud was the lead author on this article that kind of looked at 3 different institutions. And they found, can you go to the next slide? That of about 2,500 residents, 1,000 responded. And when they were asking the questions, the things that we like that are just so egregious, like threatened, denied grade, sexual favors, should never happen, but we're on the lower end of the spectrum of things that happened. 16% still offensive sexual remarks, but here this like 23% were publicly humiliated. So I started kind of like wondering, what is the experience of our residents? How do they perceive mistreatment? And is it this thing that seems to be listed, right? Because there's these aggressive behaviors that we can point out, but like, what is it about the day-to-day? So there is one article in the literature for mistreatment for medical students that identified kind of incident-based and environmental-based. So my interest really lies in kind of environmentally based mistreatment, which are those little kind of day-to-day things. All right, let's go on to the next slide. So what do we know about it? It's common, it occurs across specialties, several perpetrators. So time and time again, faculty, residents, nursing, residents to students. And the thing that really interested me, piqued my interest, was resident to resident. And we don't really stop to think about that, but that's a place where we can stop and be intentional because they're still developing and they're role modeling what they're seeing around them. And so can we take some time and mirror that back to them? And that's where focus theater, forum theater, in my mind came in. So, and the other part, we're often focused on the incident-based, but I wanted to shift my focus on the environment-based aspects. And the more I do this work, the more I realize that the common denominator is respect or lack thereof, which I think was one of the key concepts in crucial conversations. Like without respect, you can't move forward. So it really is a key concept. Okay, let's move on. And the chat is moving too fast for me to read, so I'll have to catch up a little bit later. Okay, so forum theater is a way for us to act out scenarios and work through them. Okay, so let me just start with what we do. How do we make this relevant to the residents themselves? And my interest was in resident kind of peer-on-peer mistreatment. So stakeholder support, I worked with Dr. Paige Ramsey in our pilot, which we just got our manuscript accepted today in academic medicine. I'm super excited. And so it's like kind of a big load, but I'm super excited about that. So stakeholder support is really important. And so she felt this was something that was really important. And, you know, it was a win-win because I then have access to a group of residents, and then I hopefully can offer her a curriculum for professionalism, which is another piece of this, right? The ACGME wants us to look at professionalism as a competency, but we don't yet have a lot of curriculum in that regard. So this was filling a need there. So we talk to the residents, and we don't have any faculty from the program. We really tried to make it safe for them. And we just got their stories. We said, hey guys, what's your experience with mistreatment? How is it showing up for you? What are you seeing? And we wanted to focus specifically on the resident to resident interaction. So we asked about that. But they end up taking you where they want to go. And I think in this particular group, nursing interactions, but you know, kind of rose to the top. And so that's our project now that we're working on. But we maintained our kind of focus on the peer-to-peer stories. And what rose to the surface there was bullying and gossip. And gossip is a really interesting one to me because it's very insidious. And people, if it's part of the culture, don't really think twice about it and don't really recognize how it can make a good culture not so great. So then we got a couple of volunteers, again with program director support, and met with them for 2 separate hours, kind of outside of any curriculum at a time. And we fed them and all of that great stuff. And said, here's what came out of the focus groups. Does this resonate with you? And they were like, oh yeah. And then I was like, can you think of a scenario that would, you know, do you want to do one? Do you want to do another? can you think of a scenario that, we could use? And so they came up with a scenario about a resident that was kind of bullying an intern for not doing the right thing. And so that intern was kind of berated in front of everyone. The chief walked away, and then the gossip starts. So the intern's gossiping with the third year, the intern walks out, the chief comes back, the chief's gossiping with the intern. And to kind of up the ante, they kind of had it, they said the interaction happened at the nursing station, so it was kind of a little more visible. So we just, we came up with that scenario, we wrote it out, so I wrote it down, and then we came back for 1 more hour to practice the scenario. Before this gets too overwhelming, let me just stop and say, maybe you don't want to go all the way to theater, but if you do the focus group or have someone do that for you, you can get a lot of information, and maybe from there identify, maybe conflict. They don't know how to manage conflict well. Let's implement, crucial conversations. And so I think just by doing the focus groups, you can start to hone in on what the issues are. And then there's lots of great interventions and tools out there, especially in the business world. And maybe you can curate some of that if this theater thing seems a little overwhelming. Okay, so then we get another hour of didactic time, 1.5 hours or so, and we play out the scenario to the whole group. So we have the resident volunteers. And the thing about forum theater is then we get to stop and start the scene. So we play the scenario, and it's kind of like, if you will, a trigger video. It ends in a really uncomfortable kind of cliffhanger. So, we ended with the conflict where the, chief walked out, was really upset, and the resident felt really deflated talking to their chief. And then we stop the scene and we get their impressions. We're like, hey, does this resonate with you? Does this happen? Yeah, that happens all the time. How do you feel about that? Yeah, that resident doesn't feel great. They feel ashamed. Are they learning? No, they're just thinking about this interaction. And so we're kind of highlighting how these normal everyday events like really take away from their learning. And then we get to go back and say, well, do we want to continue this? Is this something you guys want to perpetuate in your culture? And if not, how do we change this? And let's start, jump in, give me some ideas on how we could change this scenario. And they just get to act it out over and over again until we resolve the scenario. And I have to tell you, this group was so great. They managed one, they got, they took care of the bullying, but they were upset that they didn't fix the gossiping. And so they kept going until they fixed both. And I've gotten feedback later that they really feel that they're much more mindful about kind of how and where they speak. But I don't know if Sarah, you wanted to jump in because you had feedback from them about, I think, future interactions that I was really excited to hear about.
Yeah, it's actually interesting because Sylvia did the first project about a year ago, and then we're working on the second one now with the nursing interactions. And one of the residents had brought up during a recent program meeting that they said there hasn't been a lot of progress yet on the relationships with the nurses, but that's because we haven't done the forum theater yet. So once we do the forum theater, that's going to really help. So it was really it was very obvious that it really was very impactful. And then I shared also in the chat that one of our chiefs, actually, we have them do self-directed goals every 6 months, all of our residents during their semi-annuals. And one of the ones that she came up with on her own was stopping and redirecting gossip when I witnessed it, which I thought, really came from Sylvia's work with our residency program. So I was really very appreciative.
Yeah, that just melts my heart, I have to tell you. All right, so let's go to the next slide. So this is kind of what I've described. You do that individual. So once you've done the focus group, you get your volunteers, you just kind of review the material, and they generate the story for you because they're going to give you the context and what's real and what's not. And then they practice the scenario in a second hour or so, and then you present it to the group at large. And again, every culture and group is different. Some people don't mind having faculty there. Others really just didn't want faculty there. And we're just trying to create that space that's safe for them to be able to talk and work through these issues. I will warn you, we did have one group, not Ob-Gyn, where we worked, and it just kind of, this is a lesson learned. There was a lot going on in the department, and those residents didn't feel safe speaking up at all, which, you know, I think if you want to use this as a tool, you got to make sure that there's at least a baseline of psychological safety where they feel comfortable discussing the issues. And yeah, you're separating them from program leadership, but that they're just even willing to talk. Otherwise, it's a no-go. Here's a picture from our general surgery group, just to show you, like, look, that's our lecture hall. We're not actors. We can't really use a lot of prompts or props. We just acted out the scenario. And, you know, our residents have really great imaginations, and they work, and they all like interacted, I think, because we got a scenario that resonated with them, right? I didn't use gossip in the general surgery group. Like, they had their own set of issues that came up, and we used that. So I think that kind of speaks to your, you know, how do you get buy-in from the residents? We'll make it relevant to them, and the focus groups is the way that we could do that. So we evaluated it. We did a pre-post and then a 6-month, and we wanted to know kind of what their thoughts about forum theater was, and did they report any self-reported changes in their behavior. And 92% said they'd recommend it as a method to teach professionalism, and 62% of residents self-reported behavioral changes in the 6-month post-op. So I think we got good outcomes with this, and so we've continued in several departments, and now we're moving into that interprofessional space with nurses. So I think that's it for me, right?
All right. That was the end of our 3 sort of perspectives. Sort of the smallest was, you know, a very small session structured around a little scaffolding from the Kern Center, something a little bit bigger, but also a bunch of different options that you could use with crucial conversations. And then forum theater, which even within it has different ways of executing it that you might be able to implement in either a large curricular change or something smaller. So we're wrapping up because time has ended, but we're happy to answer questions or hear about other resources you have to share. We're sad we're not in person, etc. So we would love to hear from you if anyone has any questions or comments at this point.
It looks like Sue Cox had something to share. Isabel, you may not be able to see because you've got your screen share on.
Yes, I will stop sharing so I can see everybody.
No, I just wanted to congratulate y'all. That was a very, very good session. I wish I had the time to implement it for medical students and residents, because it does seem very time consuming.
I also want to highlight, gosh, I got so enwrapped in what you were talking about, Sylvia. It's so unique that I lost track of time too. So thank you so much for all these wonderful ideas. I do want to highlight, again, the resource page that the team mentioned that they have. So on Whova, you can look, they have just, actually it's like what, 16 pages worth of just a lot of different resources, links, the things that they highlighted. They're also available here for us to kind of just maintain and keep as really great resources. So thank you guys so much for all of these wonderful opportunities. It just covers so much ground, right? Like everything around professionalism, but you know, all the things around DEI. There's so many things that this is so applicable to. So thank you so much for just sharing all these fun pearls.
And we're happy to collaborate. I realized that my email was left off, but please reach out to me. I'm happy to walk you through if you're interested in this process or not. Happy to collaborate. Yes.
That's exciting.
Awesome.
Need to get down to San Antonio. That sounds fun.
Hey, we'd love to have you.
Live in Texas, you know.
No, thank y'all for sticking around and staying through to our, through our session. It was really fun, and sorry we're all not in person. Miss you guys.
Yeah, maybe we'll see you in person.
Yeah.
Hopefully 2023, right?
Yeah.
Right.
Thank you so much for joining.
Thank you.
Thank you, everybody.